first presentation today by Dr. Mony Son will be inpatients who develop severe hypertension without acute end organ damage should be treated immediately and aggressively.
Hello everyone, thank you for having me and thank you for being here. So first, the objective of my talks will review the evidence for management of in-the-hospital severe hypertension for patient doesn't have any evidence of end organ damage or symptoms, and will focus on non-critically ill patients, non-pregnant, not cardiac or neurologic primary admissions, and we'll also discuss the outcome of aggressive treatment as well. Okay, so first let's discuss about the first thoughts of how this myth come about. So it started around the 1930s when people kind of fear that acute elevated blood pressure can progress to neurologic or cardiac complications. However, the question whether the acute asymptomatic elevations in blood pressure can precipitate adverse cardiovascular event among these patients has never been studied. And this is commented by Axon and his colleagues. And furthermore, the asymptomatic blood pressure elevation is common in the inpatient setting. And actually, the national guidelines recommended treating with oral agents to slowly decrease blood pressure. However, we still see that many clinicians still use IV antihypertensive medications that can lead to unpredictable changes in blood pressure. Okay, so we'll review how we should be taking blood pressure properly. If you can focus on box 1 and 2, patients should be relaxed, sitting in a chair, feet on the ground, back supported for more than 5 minutes. They should empty their bladders. They shouldn't be talking. And if the blood pressure is measured while they are lying or sitting on the examination table, that does not meet that criteria. For our patients in the inpatient setting, they usually come in acutely ill, they're in pain, they're nauseous, and they have some medication held, so it's not accurate. All right, we'll look at the first study of the safety of treating hypertensive urgency in the office setting. So this study is a retrospective cohort study looking at about 58,535 patients in the span of 3 years. Their systolic blood pressures on average is 182, about 10.2% of them about 200 millimercury, and they also have diastolic elevated at 96.4, with 5.7% having more than 120 millimercury, but their diastolic blood pressure. Of those patients, 72.9% have hypertension as a diagnosis, and at least 58.2% have taken 2 or more antihypertensive agents. So of those 58,535 patients, 0.7% were referred to the hospital, the ED or direct admissions for treatment. And the study kind of look at comparing to the safety for patients who were sent home, and they also kind of monitor their major adverse cardiovascular events in 6 months. So what they found there were no significant differences in the MACE, which is major adverse cardiovascular event, at 7 days, 8 to 30 days, or 6 months among the patients who were sent home or to the hospital, either the ED or direct hospital admissions. You can see the p-value is above 0.05. And patients who were sent home were more likely to have uncontrolled hypertension at 1 month, but there was no differences at 6 months. And obviously, if they were sent home, there's lower hospital admission rate as well. So their conclusion was the rate of MACE in asymptomatic patient is very low, and the visit to the ED just leading to more hospitalizations and does not really improve outcomes for the patients. And most of the patients still have uncontrolled hypertension 6 months later. And their recommendation is actually if we see asymptomatic hypertensive urgency, the effort should be focusing on improving outpatient follow-up, serial blood pressure control, and intensifying their antihypertensive regimen. Because referral to the ED or for hospitalization is just increasing use of healthcare resources and does not link to better outcome for the patients. Right, so with that being said, we know it's fairly safe to treat elevated blood pressure outpatient, let's see what our resident feels like in terms of prioritizing inpatient hypertensions. So this study survey their resident in internal medicine, family medicine, and surgery at 3 different sites, UMich, Medical University of South Carolina, and Spartanburg Regional Medical Center. And it's a survey-based study. And it's a pretty approximately equal distribution between first, second, and third year residents. And majority of the respondents were 66% internal medicine residents. So what they found were 86% found that control blood pressure in the hospital is fairly important. They rank it 4 or 5 out of 5 importance. And at systolic blood pressure of 160 millimercury, they saw 63% of family medicine and 57% of internal medicine would start treatment. 44% would say that they would treat the asymptomatic patient with either IV agents or an oral agent, and if they choose IV agent, there was a strong preference for hydralazine. And 91% agreed to intensifications of anti-hypertensive regimen at discharge, and those agents are what they were used in the hospital. So in conclusions, the residents were generally agreed that the management of inpatient hypertension was a high priority, and they overestimate the benefits, underestimate the harms of medical interventions for this asymptomatic patients. This is the surveys that they all took. And so the study recommended that for asymptomatic patients, take that opportunity to recognize uncontrolled hypertensions and take that opportunity to improve post-discharge care rather than intervening during hospitalizations. All right, so the next 2 studies we're going to look at the adverse outcome of aggressive intravenous antihypertensive during hospitalizations. The first one is a retrospective review in a period of approximately 1 year at a 106 bed urban hospital. And they were looking at patients who were 18 to 89 years old, non-pregnant, non-critically ill, and taking PO. The major adverse outcome, their definition was a 25% decrease of systolic or diastolic blood pressure within 6 hours and are requiring interventions such as IV fluid, tachycardic, 100 beats per minute or more than 20 beats per minute at baseline, or bradycardic, less than 50 beats per minute. If there's a whole of their schedule, blood pressure medication, and change in level of care, change of mental status, stroke, TIA, or chest pain within 30 minutes to 6 hours of administration. So they found that 246 patients have episodic IV and antihypertensive order. Among those, 172 received 458 doses, 48% receive a single dose, so the rest receive at least 2 doses. And over 98% of the episodic IV antihypertensive was given to systolic blood pressure less than 200. 84.5% of those were given to systolic blood pressure less than 180. Hydralazine was the preferred agent, IV, and they also saw that hydralazine intravenous significantly lower blood pressure comparing to metoprolol. And then within 6 hours of administrations, there were statistically significant decline of average systolic and diastolic blood pressure for those who receive IV hydralazine and labetalol. And then if you focus on the graph on the left of the screen, it was comparing hydralazine to labetalol and metoprolol, and the highlighted number was the systolic blood pressure, and you can see it can reduce to approximately 30 millimercury of the systolic blood pressure. So the adverse outcome that they found was 32.6% of those patients have blood pressure reduced more than 25% within the first 6 hours. 2 of those got IV fluid for treatment of hypertensions. 6 had their oral scheduled BP medication held, and those who have IV hydralazine given had heart rate more than 20 increase from their baseline, more than 20 beats per minute. and 7 were having heart rate more than 100 beats per minute, and 1 that got labetalol had bradycardia. And those were the only adverse outcome that they found. So their recommendation was against use of IV antihypertensive agents, and if you really wanted to treat asymptomatic patient, they would recommend it slowly with PO route to reduce that severe hypertension. The unnecessary use of IV antihypertensive agents it's just increasing unnecessary risk and cost, and sometimes it's 10 to 100 factors more expensive than the PO counterpart. And then the adjustment of patient's oral regimen or observing the patients are probably the only intervention that you need to do. And again, coordinations in ambulatory follow-up. So this is re-emphasizing again and again that outpatient follow-up is crucial. Okay, the next one is still again looking at adverse outcome. Is a bit more recent study in 2021. Once again, retrospective cohort study of 22,834 patients in the spans of approximately 1 year at a 10 hospital part of Cleveland Clinic Hospital Healthcare Systems. And they were looking at adverse outcome. They were actually measuring acute kidney injury, myocardial injury for patients who receive IV antihypertensive versus getting a new class of oral antihypertensive agent. So they found that 31.1% were treated, so about 5,900 patients, and the treated patient have higher rates of acute kidney injury, statistically significant p-value less than 0.001, and also myocardial injury, p-value of 0.003. The treated patient also have longer length of stay, again, statistically significant as well. And among the patients with the systolic blood pressure more than 160 millimercury, treated and untreated patient had similar reductions in their systolic, more than 20 millimercury or more. So doing nothing or doing something will bring it down to about the same range. And 9% of those patients had their antihypertensive regimen intensify, the one that received IV treatment. This is the table of the result that we discussed. And their recommendation was, they found that intensification of the therapy without signs of end organ damage was associated with worse outcome. The lack of harm among untreated patients kind of support conservative approach, and simply just repeated blood pressure 4 hours later could substitute any interventions. Last but not least, we have a solution. So this study is actually an interdisciplinary quality improvement interventions at a pretty big hospital, 1,134 beds, tertiary medical center, part of Mount Sinai, and it was conducted for about 1 year. The participants are those who provide care to the patient, including nurse, house staff, NP attending on teaching and non-teaching service as well. And component of their intervention was education, including nursing huddles. They give treatment algorithm separately for the nurses and the providers, and also kind of giving audit and feedback. They have a very cool thing. They utilize EMR to have a warning for the providers before signing their orders or placing the orders for IV antihypertensive. And the two medications that they put those warning were labetalol and hydralazine. So to the right of the screen, you'll see the treatment algorithm or assessment algorithm for the nursing staff. If the patient has systolic blood pressure more than 180 millimercury or higher than the baseline, they need to check if they have any symptoms. So if they have symptoms, have they looked into other etiologies yet? And they have the list of alternative etiology that they questions. And if those etiologies presented, then they would treat those alternative etiologies such as pain, nausea, delirium, and if they have their medication held or even being in a volume overload status. If those etiology does not present and they're symptomatic, then they would call the residents, house staffs on call, and then present what they found to ask for treatment. And then similarly, the one on the left would be for the provider, kind of go through similar algorithm, and they have a really nice recommendations of what to do. So if it's hypertensive urgency, they have a reminder for you to lower no more than 25% in the first hours and following those recommendations. And if they decided to treat hypertensive urgency, then they have a list of agents as well, and nicely summarize of onset of actions, durations of actions, and what the initial dose they should start on. Okay, so the result was that overall there were less adverse events that they see, and also kind of decrease the inappropriate one-time IV antihypertensive reductions of 60%. And they were doing, like as a safety measure, they were comparing, looking at patients who received treatment versus those who does not, and looking at adverse outcome, and there was no adverse outcome that they found. And as a cost analysis as well, I think this is interesting. The hospital-wide, they found that it's $17,890 hospital-wide cost for unnecessary IV antihypertensive medications. And they estimated the cost reduction if they were to remove those unnecessary order, the hospital could have saved $10,662. So what we talk about this graph is just to show the decrease of unnecessary IV antihypertensive after they start the interventions. And this is the data that we discuss in the result. And this table over here shows what's the most common alternative etiologies, and it was most commonly pain. Okay, so their recommendation was to have an interdisciplinary intervention, and that can successfully reduce the unnecessary orders, addressing the knowledge deficits among nurses and physicians. And nurses' assessment is actually a big component, so the provider can acutely triage what to do for the elevated blood pressure. So my conclusion is, from my reading, hypertensive urgency can be safely treated as an outpatient diagnosis, with the focus on gradually lowering the chronic uncontrolled hypertensions and controlling the long-term sequelae. PR and IV antihypertensive, especially labetalol and hydralazine, can rapidly lower blood pressure, and it has high potential for adverse outcome. Expediting outpatient follow-up is the only urgent intervention needed for the inpatients with severe hypertension, and it's an opportunity for us to reinforce outpatient routine PCP follow-up. And remember to use blood pressure as any other vital signs as a hint is it new or existing underlying process, and to think before we take action. And I have a slide on implicit bias. Obviously, you have to look at data. In quick summary, they were looking at guideline recommended for patients. Guideline recommended in terms of prescribing antihypertensive for Black African American and non-Black African American, and they found that majorly Black African American receive thiazide diuretic and calcium channel blocker as a single or even as two drugs agents. Not a lot receive ACE or ARBs, and they found that a lot of Black African American have uncontrolled hypertensions. So they recommended to not use race-specific medication guidelines, and spend more time focusing on what matters, such as social determinants of health, looking at hypertension disparities, lack of access to healthy food, unstable housing, social isolations, and difficulty paying bills. That's my reference, and thank you.
So I don't usually do this, but I threw in two quick slides, mainly because this is the, when I was a resident back in the day, we used to write PRN orders for high blood pressure over 180, 190, whatever it was, to give sublingual nifedipine. This paper came out in 1990, and it was probably, I would guess it was one of the most frequently ordered PRN orders in the country, nationwide in the United States, to give that. I don't know if any of you remember, any of the older gentlemen or ladies in the audience remember that. But in 1996, this article came out, and after this article came out, everybody basically stopped using nifedipine for treatment of very high blood pressure in the hospital. And I have a lot of problems with this paper. It's based on like 10 case reports, most of which probably shouldn't have been treated in the first place. But the thing that I wanted to point out is the title of this article, because they coined this term called hypertensive pseudoemergencies. And that's basically what this is. When you get a patient with a very high blood pressure, asymptomatic, no acute end organ damage, it's not a hypertensive emergency, it's a pseudoemergency because somebody is calling you to fix this problem right now. And it doesn't need to be fixed. And they even said, to the contrary, an asymptomatic patient without target organ disease who presents with excessive blood pressure values is more often than not a pseudoemergency in whom precipitous lowering of arterial pressure is unnecessary and even contraindicated. And unfortunately, this was an oral agent which was probably safer than all of the IV agents that are being used now. And what happened was people stopped using this agent and went to IV labetalol and IV hydralazine, which are actually, I have seen many episodes of severe drops in blood pressure from those drugs. So they went from a reasonably safe drug, and instead of taking really what the bottom line of this study was, these people shouldn't be treated at all, people started treating them with IV drugs. So it actually made the problem worse. Okay, so that's the only thing I want to say about that. All right, so before we get into the myth and voting, we're going to have a quick discussion. Dr. Fitzgibbons is on Zoom because she's ill today, and she texted me. How does Mony recommend communicating to nursing who are worried and have been taught differently? Which pretty much not just the nursing, but physicians have been taught this for many years, that these people need to be treated inappropriately. So I think so. How would you address that with a nurse that calls you at 3 o'clock in the morning that Mr. Jones, who has no other, is asymptomatic, but his blood pressure is 190, and you're going to say, well, don't do anything and check it again in 4 hours based on your, right? Mm-hmm. But how are you going to educate that nurse? Because that nurse, I guarantee you, will be calling you back.
Yeah, so I actually have a great PowerPoint. You can watch at 2x on YouTube. Medical Mythbuster. But I think I would go through what's the new evidence out there and kind of continue to educate the nursing staff. It's now that it's a myth, it's been busted, hopefully.
So you can direct them to this YouTube.
Exactly.
Okay.
It's useful.
Anybody have any other thoughts before we move on? Yeah.
Great talk.
Well,
totally agree. I think we push way too many antihypertensives in the hospital. A situation I'm interested in, I think we could not treat blood pressure in sometimes, but I think leaves a little bit to be desired, is somebody with, let's say, an AKI that's better explained by another cause with a very high blood pressure. Should you treat that, or should you wait? Somebody that has a very high blood pressure with an AKI that's better explained by another cause, should you ignore the blood pressure or give them some orals or just push something to cover your bases?
I guess it's depend what's the other causes. Is it fluid overload that now you need to better diurese them, right? Because
so if it's not acute end organ damage due to the blood pressure and there's another cause for that, then you don't probably need to treat it that aggressively. Yeah.
To help answer the question that Dr. Fitzgibbons posed, I love that slide that you had that they used in Sinai.
Yeah.
I think adding that as, you know, how we have all in the nurses' rooms during the nursing huddles and stuff, they have those in like the sepsis ones, you know, having just a table like that incorporated and then having that be part of their workflow when they're charting the blood pressure. If it's above 180, that like pops up and that's what they run through.
Yeah. So after I saw that study, I think it's a great opportunity for us to do a QI project.
Which Mony's going to do, so don't anybody try and steal the idea. So, any other comments? No? Okay, well, I guess we're going to vote. Is it a myth? Inpatients who develop severe hypertension without acute end organ damage should be treated immediately and aggressively, i.e. hypertensive pseudoemergency. So how many people think that this statement is true? We should be doing this. How many think it's plausible? How many think this is busted, completely busted? That's pretty unanimous. A rare event. All right, we're busted.